All right, I should be streaming again. Let's see. Testing, testing, 1, 2, 3. Is this working? Nice. Okay, now we're working. And let me try this. Exclamation IV tutor. Explain everything you need to know about. There we go, folks. It's working. Now let me test YouTube just in case that works too. That's notoriously much more tricky to do. Good enough. Okay, I think we're ready for the next question. We've been on that one for a while. Question 85. All right, so here we have a 38-year-old woman from Ohio presents to the clinic with a 2-week history of fatigue, weight loss, and dry cough. She mentions that she recently spent several weekends hiking and camping in the woods. Her temperature is 38, blood pressure 118 over 76. Auscultation of the chest reveals diffuse rails. A CT scan of the chest shows multiple small nodular opacities through both lungs. Bronchial lavage is performed. A microscopic examination shows small intracellular oval bodies, which characterizes the cell wall on this patient. All right, so Ohio, dry cough, weight loss, intracellular oval yeast makes us all think of histo. So this is Histoplasma capsulatum, and this is an intracellular organism inside of the macrophages. And So that's going to be fungal pathogen that survives within the phagosomes. And then camping, hiking, all that stuff, fungal infection from bird and bad droppings in the caves and the soils. Fungal cell walls have chitin and glucan, and not peptidoglycans or lipopolysaccharides. So we can immediately cross out peptidoglycans and lipopolysaccharides. They don't have those. They have chitin and glucan instead. So our answer is going to be D. Intracellular oval bodies tells us is histoplasma capsulatum. Camping affirms this as well. Small nodular opacities is that fungal pattern, the nodular opacities. Fever, dry cough, and fatigue, subacute presentation of fungal pneumonia. So histo, dimorphous fungus endemic to Ohio and Mississippi. You just have to know the differences. Peptidoglycan, gram stain found in bacteria. Cellulose is in plants. Ergosterol is antifungal drug target, so it's found in the fungal cell membranes, not the cell walls. Not the cell walls. Characterizes the cell wall. That's the reason why it's wrong. Because ergosterol is in the cell membranes. So we just got to distinguish between these infection forms. And histo is the most common endemic fungal infection in the United States, right around Ohio and Mississippi. Okay, intracellular oval bodies in macrophages indicate pulmonary histoplasmosis caused by histoplasma capsulatum within a cell wall containing chitin. So here we're dealing with a 38-year-old woman who just got back from hiking, now has dry cough and fever and weight loss. Histo. Fungus lives in soil contaminated with bat and bird droppings and enters the body through inhalation. Ergosterol is part of the cell membrane. All right, so now let's talk to our 38-year-old and let's see what's going on.
Sorry, it just keeps coming. Take a deep breath for me and out. All right, you can relax.
I'm so tired all the time. I've lost almost 10 pounds.
Your scan shows small spots scattered through both lungs. The sample we took shows tiny yeast inside your immune cells, likely from the fungus.
All right. So it's that fungus on inhalation in Ohio containing chitin, not peptidoglycan cellulose or lipopolysaccharides. So there's our patient, there's the presentation, and here's everything you need to know. Hey there, Jim. How's it going? I'm currently gonna have to buy some more credits, so I'm just looking in how to do that. Okay, we'll go on to our next question regardless. So we're on question 87. I'm just gonna purchase some more credits because I got like 12 bucks from the channel, so I'm just gonna reinvest it all back into the channel anyways. All right. And a 55-year-old man. This is gonna be cool. I just purchased some more credits so that you guys can watch more of these. It was only like 10 bucks, so I don't mind it. And whenever that loads, we'll have a really awesome question. I'm excited for this. Here we go. So, a 55-year-old man presents to the emergency department with acute shortness of breath, wheezing, and facial swelling. He reports after these symptoms started about 20 minutes after he. Okay, so these symptoms started 20 minutes after eating shrimp, which he's never eaten before. And on examination, he appears anxious and is using his accessory muscles to breathe. Vitals, which you can see over there accurately, are going to show his blood pressure of 100 over 70. Normally it's 90 over 60 to 120 over 80. Heart rate is 110, which you can also see there accurately. And respiratory rate is at 28, which you can also see there accurately on his patient vitals, which I love that. Program that in for you guys. Oxygen status 92 on room air, normal is 94. An immediate management plan is initiated, and the blood samples are sent for analysis of mediators involved in anaphylaxis. The lab reports show elevated levels of histamine, tryptase, and leukotriene C4. Which of the following complement proteins is most likely contributing to the pathophysiology of the patient's symptoms? Jim, thank you so much. I love that. Pouring some milk with cereals, enjoying the live stream until you fall asleep. I'll try to keep it nice and conducive to the atmosphere there. Okay, so here we go. Let's talk about all of these different answer choices. We have to know and distinguish between all of them. So let's start out with C. Well, let's just actually start out with like a high yield summary of what's even going on here. So C3A is a molecule that is involved in anaphylaxis. It's an anaphylotoxin, and this leads to mast cell degranulation and then release of histamine. Okay, so that's 3A. C5A is also an anaphylaxis that's going to be neutrophil chemotaxis. Okay, C5A is neutrophil chemotaxis. Chemotaxis. C3B is opsonization. C3B, opsonization. And then C5B to C9 is the membrane attack complex. And then C1Q is going to be involved in your classical pathway initiation. All right, so that's what all these secret little codes mean, you know. And so when somebody is stung by a wasp or suddenly develops a flushing or swelling or wheezing, that's anaphylaxis, right? And it's a massive IgE driven mast cell explosion. So the mast cells release histamine and tryptase, but the complement system so remember we talked about, our complement system in another one of our videos here. The complement system is going to kind of exacerbate this issue. So you have fragments like C3A and also C5A. These are the anaphylaxitoxins. Anaphytoxins. The anaphytoxins are going to trigger more mast cell degranulation and increase vascular permeability. And so C3A is going to be most closely linked with vasodilation and also airway constriction. And so the allergic reaction and the complement mediated fragment is going to be responsible. The C3A is going to be involved in that pathway very heavily. So we have an allergic reaction, and the complement fragment most involved is C3A. And so the big takeaway here is that we get this basically gram positive is going to have a thick peptidoglycan. It's going to be purple. It's going to be no lipopolysaccharides. And gram negative, of course, is our pink stuff like LPS endotoxin. And anaphylaxis is an IgE mediated mast cell and histamine that's going to be amplified by C3A and also C5A. And these are known as the anaphytoxins. You got free? What is that? What are you talking about, hematopoiesis? Okay. By the way, you should be able to vote in the chat. You should be able to vote on answers now. All right. So basically what's happening here is we have shrimp ingestion, which causes swelling, wheezing, and hypotension. That's a type 1 hypersensitive reaction, so it's anaphylaxis. We get that. There's elevated histamine, tryptase, and leukotriene C4, and that confirms a mast cell and a basophil degranulation as well. And then the complement fragments C3A and C5A are anaphytoxins that trigger mast cell degranulation. All right, so C3A, and then you don't see C5A, but they're anaphytoxins that trigger mast cell degranulation that amplifies the allergic reaction. And C3A is especially interesting here because it causes vascular leakage and smooth muscle contraction and bronchospasm. And that's the symptoms that this patient has. And you guys are in for a treat because we're actually going to be we're going to be watching a really awesome video about this one too. I'm excited for it. So anaphylaxis amplifiers, C3A is an aflatoxin. An aflatoxin, it contributes to mast cell degranulation. Histamine and leukotriene C4 are products of mast cell activation. And tryptase is a marker for mast cell activation. Hematopoiesis says they got an exam tomorrow, procrastinating until they get enough channel points for push-ups. Oh boy, it looks like we're gonna have to do some working out today. All right, so basically, type 1 hypersensitivity is an IgE-mediated response leading to mast cell degranulation. It causes release of histamine and other mediators that lead to vasodilation, bronchoconstriction, and shock. Complement proteins like C3A and C5A act synergistically with the IgE pathways by further enhancing mast cell activation and chemotaxis of inflammatory cells. The overlap between innate and adaptive immunity is critical for anaphylaxis pathophysiology. So the shrimp allergen, and you get the facial sweating and all that stuff, is anaphylaxis. Tryptase and leukotriene C4 are elevated, and then you get mast cell These are mast cell degranulation markers, and C3A and C5A are anaphylotoxins. They promote histamine release, which increases the permeability, and it causes all those symptoms. IgE binds here on the mast cells, cross links and repeat exposure, and you get immediate degranulation. Tryptase is unique to mast cells, and it's a marker for anaphylaxis. The tryptase levels are going to be elevated. C3 deficiency is going to be seen in recurrent pyogenic infections, not related. Okay, so here's our bottom line. C3A contributes to anaphylaxis by promoting vasodilation and increased vascular permeability, leading to acute respiratory distress. All right, this is going to be explaining the mechanism to us. So everybody enjoy. This is going to be really fun. Here we go. I purchased this just for you guys. I literally paid $10 so you guys could all see this. Here we go. 3, 2, 1.
A 55-year-old man eats shrimp and the allergen crosslinks IgE bound to mast cells. This triggers rapid mast cell activation with release of histamine, tryptase, and leukotrienes. Complement is engaged, generating C3A, which amplifies the mast cell response.
Oh, C3A, amplifying the mast cell response. Also C5A, be on the lookout for that one because it mediates inflammation and mast cell and basophil degranulation. And degranulation of those cells results in the increased concentrations of histamine, leukotriene B4, and serotonin. So C5A, big chemoattractant, activates your neutrophils and your macrophages. Kind of fun, huh? It's kind of fun. Jim says, nice. Did you like that? Was it worth the $10? I think so. All right, I got to stand up. I've been sitting for a while, but here's the next question. Everything is going to be loading in a second. Jim says it was definitely worth it. Matapoesis, do you have any channel points? I'm feeling like I got to do 10 push-ups. If you got any, or 20 push-ups. Maybe I could like do push-ups myself so I can preempt them. Oh. So that I don't have all of them catching up big time. All right, guys, here we go. Next question is a 35-year-old healthcare worker is preparing to receive the annual vaccination as part of a mandatory health program. The worker is in good health, no chronic medical conditions, no known allergies. During the discussion, the physician explains the vaccine contains components to help protect against future influenza infections. Which viral components targeted by this vaccine is essential for the virus's ability to attach and enter the host cells? Jim says 15 consecutive full form push-ups. Okay, sounds good. You're not on Twitch, but if you're on Twitch, you can actually redeem channel points and make me do them. But just for you, Jim, I'll do 15. So Which component targeted by the vaccine is essential for the virus's ability to attach and enter the cells? So we have annual vaccination, and we're protecting against future influenza. So we have to know how this works. Okay, so let's talk about the influenza virus. So it targets the surface glycoproteins that the immune system recognizes. The influenza vaccine does. And so influenza vaccine is going to be targeting like hemagglutinin and also neuraminidase. And hemagglutinin is the viral protein that's responsible for binding the sialic acid receptors in the host epithelial cells. And that's what allows the viral attachment and entry. So hemagglutinin is this viral protein that's responsible for binding sialic acid receptors on the host epithelial cells, and that allows the viral attachment and reentry. And neuraminidase, by contrast, facilitates the release of the new virions from the infected cells. So hemagglutinin is going to bind to the sialic acid receptors for viral entry. Whereas neuraminidase is going to cleave the sialic acid and it causes the release of the progeny. So what do we think the answer is going to be here? Well, is it NS1 protein? That is a non-structural protein. It inhibits the host immune response, but it's not going to be involved in entry. How about RNA polymerase? So that's used for viral genome replication inside of the host cell. So not for attachment. So you can cross that one off. Neuraminidase, that cleaves sialic acid to release the new virions. So the role is involved in exit, not entrance. So that's wrong. That's inside. NS1, we said, is non-structural, inhibiting the host immune responses. So this is suppression, so it's different. NS1. M1 matrix, that's involved in structural integrity. Jim says A, hemagglutinin, and you would be correct. That is indeed the answer. Hemagglutinin binds sialic acid in respiratory epithelial cells to mediate viral entry. It's the primary antigenic component of influenza vaccines. They're updated yearly due to antigenic drift. Hey, Big Busty05. What a funny name. Welcome. You are my first chatter on Kick. So really good to see you there, Busty. I'm going to call you Bust. I'm going to call you, I don't know what I should call you. Your name might be problematic if I say it all the time. Yeah, good. That's awesome. You are a first listener on Kick. Cool stream. Thanks, man. Soon I'm going to add some APIs so that your Kick chat can be presented to everybody else who's watching on YouTube, Twitch, and X. That'll be coming. I'm doing a lot of coding, as you can see. But I just bought $10 worth of video credits, so we're going to exhaust them all in the stream. Alrighty. Jim's laughing. Jim can't see his name. So you guys, Twitch, say hi to YouTube. You know, all YouTube, say hi to Twitch, and then you guys can all say hi to Kick as well, and X. So hemagglutinin is the influenza virus key surface protein that binds the sialic receptors on host respiratory cells, initiating viral entry. Okay, because of its crucial role in infection and immune recognition, it's the main target for neutralizing antibodies and therefore the primary component included in influenza vaccines to stimulate protective immunity. And we talked about all these guys here. Jim says, hi, Twitch, X, and Kick. I know that Kick can't see that message, but I'm relaying it to you guys. Jim is saying hi to you, Big Busty05. Alrighty. It cracks me up. You guys, and then Big Busty05 says, hi, Jim. You guys are now friends. Jim, I know that today the biggest desire of your heart was to make and be good friends with Big Busty05, and I'm glad I could make that happen. Here is the bottom line. Influenza vaccine targets hemagglutinin, essential for viral attachment and entry into the cells. Now let's check this out. Here we go. I'm going to refresh this page. All right. Now let's check out our Big Busty. Thanks for the follow. I feel like Shane Gillis, the OnlyFans dad, when I'm saying that out loud. Thank you, African Rose. He's like, he goes, I'm not a whore. Thank you, African Rose. I feel like I'm saying the same thing. I'm just like, yeah, I'm embracing the streamer life. Oh, thank you, Big Busty05. Jim says thank you for the connection. Yeah, glad you guys could be friends. You guys are cracking me up. All right, let's dive in here. We're dealing with some semi-serious content. Here we go. Let's listen to this doctor explain to this AI patient how these vaccines work. 3, 2, 1.
This is your annual flu shot. It's designed to train your immune system to recognize key pieces of the virus before you ever encounter the real thing.
And what exactly is it targeting?
One of the main targets is a protein on the virus's surface called hemagglutinin. It's the part the virus uses to...
All right, hopefully you guys enjoyed that. Hemagglutinin is the part of the virus that's used for attachment and entry. That's what that doctor was about to say. Oh, Big Busty is getting their flu shot on Monday, already booked, but now they're excited. I'm so glad we're making somebody excited about their flu shots. You should definitely say, hey, doc, are you giving hemagglutinin because it's used for attachment and entry? Or would you be giving me, is this virus going to be involved with neuraminidase, which is viral release and spread? And I'm sure they're going to look at you and say, man, Big Busty, thank you so much for asking me that question. I don't know. My MD was 25 years ago. Just kidding. They will respond saying hemagglutinin, right? The attachment and entry. Because influenza, it's an enveloped, segmented, negative sense RNA virus, right? And it has two major surface antigens that change frequently: hemagglutinin, neuraminidase, viral release and spread, right? So influenza, enveloped, segmented, negative sense RNA. And you're from Finland. I'm going to call you BB. BB is from Finland. Yes, that's true. Jim, I love these latent laughs. This is fun. Yeah, so actually BB asked an interesting question about Finland, which we can talk about in a second, because I always love diving into some of that like public health stuff. But as long as you guys know for this one, BB is actually your name. Oh my gosh, that was like crazy. That is actually scary. I promise I did not look you up beforehand, but good to know. Jim, just so you're in the loop here, anybody on YouTube watching later, Big Busty's name is actually BB, so I'm calling him BB now. That's my appropriate name. This is the last you'll ever hear me talk about Big Busty on stream. I don't know what I'm going to do when I edit this later for YouTube. But BB asked an interesting question about Finland and who, right? Who decides what goes into the flu shot? And so, Rib Big Bossy, that's funny. But yes, the World Health Organization, WHO, sets the recipe for the flu vaccines each year. So twice a year, WHO gathers data from over 100 influenza surveillance centers all around the world, and they study which flu strains are spreading and how they're changing, they're mutating. And for step one, you need to know that's antigenic drift, right? And based on that, WHO recommends which 3 or 4 strains are going to be put in this year, right? So typically they do like H1N1, H3N2, and then maybe 1 or 2 influenza B lineages, and they decide which ones are going to be put into the season's vaccines. And then each region or country then uses that guidance to manufacture the vaccines. And so the recipe is the same worldwide. It's from the WHO. And the formation and manufacture can differ by country. Some of them are egg-based, some are cell-based, some have recombinant versions, things like that. All right, but Finland is going to follow the EMA, the European Medicines Agency, and also the WHO Europe guidance. And so the flu vaccine that you get is going to have the same exact strand as the one that I got last week, and that's just distributed by approved European manufacturers, right? So that's the difference there. Hopefully that answered the question. Don't want to get off too big of tangents here, but that's the idea. All right, time to spend the rest of the $10 that I invested into this stream with another question. Hematopoiesis. I'm just seeing you now in the Twitch chat. I wish that your chats would show up on my thing. Oh, now they will. Hold on. Oh, no, they won't. Dang, sorry. I'm trying out here. I'm trying hematopoiesis. I promise I see you. BB and I are the same person. Yeah, I got it last week as well. Yeah, after this stream, I'm going to do a lot of debugging. Oh, hematopoiesis. Yes, we can see you now. Just check back when you hit the ups button. Okay, sounds good. I've got my alerts ready to go. And I have to make sure that I add. So BB, you can see Twitch now, which is good. I want to make it so that it's actually, Jim says, hey, Greece here. We're kind of close, BB. So just so you know, Big Busty and Jim, you guys are talking to each other. So BB, if you want to join YouTube, then you can say hi over there as well. But let's dive in to our next question. I've got it generating. I just spent the next little batch. BB asks, are these MCAT questions? These are not MCAT questions. These are actually medical school questions. So like, if I don't know, are you studying for medical school, BB? These are, all of us have already made it into medical school, and now we are studying so we can pass our medical school board exams. So that's what this is. But we also do some MCAT prep as well. So just message me. I like to make sure that everybody's taken care of in my chat. All right. Jim says, let's focus and get on spend these next $10. Let's do it, guys. I made $12 last week, and so I put all of the money back into the stream. So here we go. A 56-year-old woman is undergoing a liver transplant due to end-stage liver disease caused by primary biliary cholangitis. A new liver is perfused and initially appears healthy. However, within minutes, the organ becomes dark and mottled, and the surgical team notes absent portal and hepatic venous outflow. Immediate intervention reveals significant destruction of hepatic vasculature. Which process is most likely responsible for the observed condition? All right, so let's break down just the essentials. I kind of went highlight happy there. And here's what I want you guys to be doing on exams. Just think of the most important things to highlight here. So we got a 56-year-old woman, and she had a liver transplant due to this, which was caused by biliary cholangitis. Now it's perfused, but look at this. That's super important. Highlight within minutes. Within minutes is going to be probably the most important part of this question. Right? Because within minutes means that it's hyperacute. BB's in accounting. Oh, that's funny. Yeah, BB, we have a lot of people from Twitch who are studying all sorts of things. And so, maybe you could just like do your counting, mute me, just get just whatever it takes, and just lock in for a bit. But it looks like hematopoiesis, we can see hematopoiesis's chats are not coming into my multi-chat, but I look over here and I see them. And hematopoiesis has voted on A. And hematopoiesis is correct. Antibody-mediated destruction with the fibrin deposition. All right. So let's dive into this, shall we? This is hyperacute. Indeed, you're right. This is hyperacute. Darkened mottled graft, classic for graft failure. So darkened mottled graft is going to be involved with graft failure. Absent portal and hepatic venous outflow is vascular thrombosis. Significant destruction of hepatic vasculature is fibrinoid necrosis. And so dead on arrival. Hyperacute rejection is a type 2 hypersensitivity reaction involving preformed host antibodies attacking the donor antigens, typically ABO and HLA mismatches. All right, so that's important, this mechanism. Type 2 preformed host antibodies attacking the donor. Okay, so you goofed up. You got a type 2 interaction between the host antibodies and the ABO HLA. And then that activates the complement. And you have endothelial damage, fibrin deposition, and thrombosis. So it's hyperacute rejection where the recipient antibodies target the donor. Okay, you're targeting the donor. So it's kind of like host versus graft disease. But you're targeting the donor. Chronic small bile duct degeneration, that would be chronic if it's, because it even says it there, but basically it takes a long time. You get gradual bile loss. Accumulation of neutrophils, that aligns with acute. Acute is a cell-mediated T cell that occurs days to week later. Oh, hematopoiesis has some questions. Hyperacute, B or T cell? Yeah, okay, B cell says hyperacute. Yeah, so what you should know about hyperacute is it's within minutes and hours, and the immune type is definitely B cells because they're antibodies, right? B cells. And the mechanism there is you have the preformed anti-donor antibodies, and that activates complement, causes thrombosis. Acute is T cells, okay? But that's days to weeks. Hyperacute, B cells. And maybe you can remember in the alphabet, B is before T, right? And so hyperacute occurs within minutes, and so it's quicker in the alphabet. B is quicker. Acute is later on in the alphabet, so it's T cells. They're cellular, right? Cellular response, you get new antibodies, that's days and weeks. So the cytotoxic T cells attack the graft cells. And then chronic is months to years, and that's T cell cytokine-driven fibrosis. And that is chronic inflammation, fibrosis, and vascular narrowing, right? So yes, hematopoiesis, I'm sorry, I'm like looking between chats, but yeah, the answer is B cell. Okay, so we kind of covered on all of this stuff. Fibrin deposition, it's ABO incompatibility, type 2 hypersensitivity. IgM and IgG binds to donor endothelial antigens. All right. So here's the bottom line, my friends. Acute hepatic artery thrombosis causes rapid liver graft failure post-transplant, evidenced by absent portal and hepatic venous outflow. And I think we're due on another AI video, so I'm going to give you two. Here's the first AI video. This is from the last one about flu shots. I got to get my money out of this, right? So here we go. 3, 2, 1.
All right, this is your annual flu shot. The vaccine trains your immune system to recognize hemagglutinin, the part of the virus it uses to attach to and enter your cells. That's how it keeps you from getting sick later on.
Got it. So that's the key target.
Exactly. You might feel a quick pinch, but it should be over in a second.
No problem. Ready?
Thank you so much, Matapoesis. I appreciate it. My mic was off. Thank you so much for saying that. I would have not known, and I would have talked forever. Basically, I said that this was exact footage of BB in her clinic last week when she was getting her flu shot. We actually pulled the security footage, and we found this. So yes, the nurse gives the shot, and she says, "Lift your sleeve," and then they inject it. Yeah, here in America, we just rip out the sleeve like this AI patient. Whenever I'm giving flu shots, I just say, "Okay, are you ready? You're going to feel a slight pinch after I rip off your clothing, only on this particular sector, so that I can inject you there." That's how we do things in America. We don't hear anything about science. That's funny, guys. I wish you could see BB's chats. They're actually pretty fire. But yes, this is actually what you're seeing here.
All right, this is your annual flu shot. The vaccine trains your immune system to recognize hemagglutinin, the part of the virus it uses to attach to and enter your cells. That's how it keeps you from getting sick later on.
Got it. So that's the key target.
Exactly. You might feel a quick pinch, but it should be over in a second.
No problem. Ready?
Yep. So that's actually exact footage of BB getting her flu shot last week. So here we go. You'll be seeing another one soon because I just generated another one, and now it's going through some awesome in-house processes to get this all working and ready to go. All right. So yeah, the liver is looking perfect right after a transplant, but then later it turns dark and mottled and lifeless. It's hyperacute rejection. All right. It's the most dramatic and deadly form of graft rejection. Type 2 hypersensitivity reaction. Okay. Type 2. It's the preformed antibodies in the recipient's blood attacking the thing that comes into the body and activating that complement cascade. You get massive fibrin deposition. Holy smoke. Somebody just redeemed 20 push-ups. Hematopoiesis is making me do push-ups. So just 1 second. Whoa. Here we go, folks. 20 push-ups. Why do I do this to myself? 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Gotta get some mountain climbers too. Woo. 9, 10. Oh, good times. Those are some good times. Ugh. Alrighty. Thank you for the push-up challenge there. I always love doing some push-ups. BB from Kick asks, what does it mean if I do push-ups and I hear a cracking noise in my arm? Well, that's a good question. Probably just some tendon irritation. You have bursitis, some cartilage wear. You can prevent that just by warming up before a stretch. But usually it's just like the tendons and the tissue moving around. Totally normal. Hematopoiesis is studying pediatric med. Singing push-ups. Hey, Profiteer, how's it going? Guys, I wish you could see big BB's chats on Kick. We're streaming on Kick, and Kick BB is being hilarious right now. Whew. In fact, let me just try to code this up real quick so that I can get Kick working. How to access Kick API. Kick dev. Create your app. Oh, okay. BB, I'm literally building a whole entire interface so that people can see your chats because the world deserves to see them. Hematopoiesis has an exam. Good luck. Everybody say good luck, hematopoiesis. Okay, sign into your Kick account. I already did that. Go to the developer tab. I'm doing that now. Enable two-factor authentication. Enable. Yeah, hematopoiesis. Gotta do some bug house. Guys, BB says good luck, by the way. You'll be able to see this as soon as I've coded the platform for BB. I summoned Danny. I'm not seeing the Twitch chats in anywhere except for on my little tiny screen. Wait, there's an authenticator app? What's the authenticator app? Is there a Kick authenticator app? Can you guys see me right now? Okay. Kick authenticator app. I'm just authenticating myself. Have to prove to the robot that I'm real on a daily basis. Which is funny. Shouldn't they be proving to me that they're real? What gives? It says scan the code. So I'm scanning the code. Oh shoot, I missed that chat. I missed the chat. I feel I need to finish my homework and then I can also play some Bug House. Oh, Danny. Hey, yeah, that's the Danny you're talking about. What's up, Danny? My boy, Danny. My boy. Oh, Danny boy, the pipes are calling. No, it's okay. Yeah, it's going to YouTube, but right now nobody can see you, right? Let's see here. Kick. But I'll be definitely editing this heavily, so no worries there. Oh, I have an authenticator app. So any authenticator app uses this. Got it. Okay, I figured this out. Now I have a Kick authenticator app, and now I press continue. And now I go here, press continue. And I'm in, baby. I'm in. Woohoo! Okay, now I have to create a new application. I'm going to call this Kick Ivy. Gets the info from Kick to integrate into my systems. Redirect URL. I don't know. Give it access to everything. Just give me 1 sec. Use the Kick API so that just like you can see Twitch on the screen, you can see Kick chats on the screen. Give me 1 second. I'm going to answer that question, BB. Okay, I'm just adding you to my server. I'm doing a whole lot of coding right now, just so you know. Working hard. And hopefully by the end of this coding, everybody will be able to see BB's chats. And BB will be able to integrate with Twitch super easily. All right, BB had a question. Do you know how long the flu shot will last inside me? Like, is the one I got last year like still kicking butt, or is it wearing off by now? Yeah, so protection is fading with time. So your flu shot from last year has worn off. The flu vaccine protection really drops significantly after about 6 months, and that's because your antibody levels naturally start to decline. And the influenza virus will mutate quickly enough, it starts to drift. So a year later, your immune defenses from last season's shot are pretty weak, and the virus changes every year. And so each year, they're going to update that. That's why WHO needs to be involved here. And so basically, even if your antibodies are still around, they don't recognize this year's version of the virus, right? So 2 to 4 weeks is peak immunity. 3 to 6 months is still pretty good. 6 to 12 months is actually starts to fade. And then greater than 12 months, you're not protected anymore. So the flu shot protects you for best 6 months. And that's why you have to get it every year. Hopefully that makes sense and answers your question. BB has another question. They asked, isn't a 92 SpO2 pretty low, or is it not a concern because she's older? Yeah, that's a good question. So what is SpO2? That's oxygen saturation, and that measures how much oxygen your red blood cells are carrying compared to their normal capacity. So normally it's like 95 to 100%, right? 100%. Borderline is 91 to 94, and low is hypoxemia at less than 90. And so age does not really make a big difference. Even in healthy adults, it should be like relatively high, but yeah, I would say it's a little bit low for sure, but they could also be stable, especially if they're known to have chronic lung disease or COPD or interstitial lung disease, but they can like live. You can live comfortably with an 88 to 92 in high altitude. The normal values can actually shift a little bit lower too, but yeah, I would say a little bit lower than what we'd like to see for sure. All right, so now let's do this one here. So we talked about ABO compatibility, incompatibility, and hyperacute reaction. So let's actually see this in practice. Here we go. 3, 2, 1. Oh, sorry, BB. It's not working yet. I was actually referring to the AI simulation. I'm doing many things at once, which it seems like that's frozen now because my computer's running out of RAM, but whatever. Just give me 1 second here. Okay, so I ran the migration. Now I have to deploy the Supabase functions, which I've done. And then I have to set some environmental variables. So just give me a second and I'll do that real quick. So I'm still doing some coding, just so you guys know. I'm working hard. We're going to get this working by the end of the stream. I'm starting the task like this. Okay, now let's see if this video plays. Still no. So let me refresh it.
new liver is perfused and initially looks healthy.
All right, guys, so check this out. Here we go. This is hyperacute rejection.
The new liver is perfused and initially looks healthy. Within minutes, however, it turns dark and mottled, and there's no portal or hepatic venous outflow. Biopsy shows thrombosed, fibrin-filled vessels with extensive tissue injury. This is hyperacute rejection, driven by preformed...
All right, that's hyperacute. Now I'm making it so it turns off my audio. My microphone becomes mute. So mute microphone. And then it toggles the Sora video. And then it's going to wait. Well, it's going to play it. So is there a way to just wait on Elgato? So Elgato wait function. Yeah, delay. So then I just delay like 10 seconds, 15 seconds max. And then I just run, I set the Shure microphone to its normal volume. -7 dBs. So there we go. I think I've made some progress on this front. And then my iPad turned off, so let me turn on my iPad again. Man, this is a long coding process, but we're getting there. All right, well, I guess we can try it now if you want to test it out again. But I might run into some more errors. I might have to configure that a little later, but I made a lot of progress. So it's really close to working now. At least I built it in the database. So now let's do another practice question because we haven't done one of those in a while. And that's the whole purpose of the stream. So moving on to our next one, question 90. All right, so here we have a woman who just came back from rural Ghana, West Africa, has high fevers, drenching night sweats, headache, fatigue, ring-shaped parasites inside the red blood cells on the blood smear. So what is this? This is malaria. Right, just came back from Ghana. This is endemic to P. falciparum malaria. You have high fevers. Yep, you got it right. It's malaria. Drenching night sweats, headache. This is cyclical fever pattern in malaria, ring-shaped parasites inside the red blood cells. And so you think of the Plasmodium species. All right, so falciparum is the most dangerous form. It's endemic to sub-Saharan Africa. Transmission is via the Anopheles mosquito, especially if you don't have prophylaxis like mosquito nets. And you have the ring-shaped trophozoites inside the red blood cells on the smear. All right, it's caused by the Plasmodium falciparum. Babesia is in northeast United States. African trypanosomiasis is sleep-ache sickness with the tsetse fly. And there you have CNS symptoms. Dengue, that's what Dr. Moise had the other day. Breakbone fever, retroorbital pain, we covered that yesterday. Typhoid fever has the rose spots, constipation, diarrhea. All right, so you have to recognize the geographic location, the blood smear findings as well. So here's the bottom line. Ring-shaped parasites in blood smear indicates malaria transmitted by mosquitoes. Mosquitoes. All right, the pathophysiology is important here. Sporozoites enter the bloodstream via mosquito bite and they migrate to the liver. And you have liver stage zysants, which are going to release merozoites into the blood. Merozoites infect the red blood cells, forming the ring-shaped trophozoites. Red blood cells rupture, have cytokine storm, and fever and chills, and also sweats. Severe forms of falciparum, sticky red blood cells, and cerebral malaria and renal failure. Kills 500,000 people every year, and almost all of them are from Africa. And you have to look at this on blood smear to find it. Sporozoites migrate to the liver. And then they infect merozoites, the red blood cells. They rupture, causes fever, chill, and night sweats. That rupturing causes that. Okay, while our AI video is loading, I'm going to do some last minute debugging here. All right, here we go. So here's our patient, and let's listen to the AI video. 3, 2, 1.
A 24-year-old woman comes to the emergency department with 3 days of high fevers, severe headaches, and night sweats after returning from rural Ghana. On exam, she is febrile with tachycardia and mild splenomegaly. Her blood smear shows ring-shaped parasites inside red blood cells.
Okay, so there we go. The ring formation in the red blood cells on the thin, thick smear, cyclic fever, which can be irregular in falciparum, And then the risk of cerebral malaria, the treatment is going to be some ACTs and quinine in some severe cases. All right, so malaria, most likely caused by Plasmodium falciparum. The deadliest type, predominant in Africa, transmitted through the Anopheles mosquito, invades the liver first and then the red blood cells next, where they replicate and they cause cyclic fevers when they burst out. Okay, babesiosis may have rings too, but it happens in the US. And typhoid's a totally different organism with different presentation entirely. All right, on to our next question. We're on 91. All right, BB, go ahead and try the chat. I want to see if it works. I don't see your response there yet. Still nothing. I feel like we're getting closer, but it's still not working. The world's not ready for you, BB. Soon, though. Soon they'll be ready. Very soon. Yeah, you're preparing for your debut. It's going to be good. It's going to be glorious. They'll be ready. Everyone will be ready. Okay, so it looks like it wasn't authorized, so I have to go reauthorize it. Okay, give it a try now. Testing, come on. Still nothing, huh? Still nothing. All good, BB. I love doing this. I actually got my undergrad in computer science. And this is my favorite thing to be doing. But yeah, while this is cooking, we'll do this question. After I download here. All right, a 45-year-old man presents to the emergency department with nosebleeds after heavy bruising for the past week. He has a history of fatigue and occasional fevers. Physical examination shows a pale conjunctiva and mild ecchymosis in the trunk and extremities. His temperature is 38, so 100.4. Blood pressure is 110/70. Heart rate is at 88. Respiratory rate at 18 per minute. Lab tests reveal a hemoglobin level of 8.5 with 80% blast and platelet is at 40K. Coagulation studies show prolonged prothrombin time and partial thromboplastin time. Bone marrow biopsy demonstrates hypercellularity and myeloblast containing needle-like cytoplasmic inclusions. Okay, what's going on here? What's our condition? All right, so basically we got a guy, he's got some anemia at 8.5, he's got fatigue and pallor, and he's got thrombocytopenia at 40K, so he's got some easy bruising and nosebleeds because of the thrombocytopenia, and the leukocytosis is at 45K with 80% blast, and so that's going to be some form of acute leukemia. So 80% blasts. Leukocytes are way up, so we have some acute leukemia. Prolonged PT and PTT is a bleeding time, so disseminated intravascular coagulation is occurring. And the myeloblast with needle-like hour rods, right? Needle-like hour rods is going to be APL. APL. So these are aggregates. The needle-like hour rods, the needle-like inclusions, are aggregates of the myeloperoxidase, which is a hallmark of the myeloid blasts. All right, so let's distinguish between all of these answer choices. The prolonged PT and PTT comes from DIC. It's the release of the procoagulant granules by the abnormal promyelocytes. And there's a 15 to 17 translocation here. It's the fusion of the PML and the RAR alpha genes, which blocks the differentiation. And so let's talk about why it's not all of these guys here. Chronic myelogenous leukemia. Okay, so chronic myelogenous leukemia, those are mature cells, not the blasts, which have chronic myelogenous CML, reminds you of the NFL. And so that's the mature blood cells. That's, remember the 922 jerseys with a chronic course and not DIC. So it's going to be a more chronic constitutive activation of the tyrosine kinase gene. ALL is lymphoid, not myeloblast. It's no hour rods, and this is ALL, common in all children, ALL. And then we have hairy cells. Hairy cells, this is going to be more for older men. Splenomegaly is going to be seen, the hairy cytoplasmic projections, and also the dry tap marrow as well. And then we have CLL, that's elderly, and there you have the smudge cells in the indolent course with no DIC. Yeah, not quite vitamin K deficiency. Acute, that was what somebody said in the chat, by the way, if you're watching later on YouTube. Acute promyelolytic leukemia is our answer here because of those hour rods. Those hour rods. A for hour rods, they're pro-hour rods. Acute promyelolytic anemia. That's the PML RAR alpha fusion. And so it's a chromosomal translocation 1517 that fuses the PML, which is promyelolytic leukemia, and the RAR alpha, which is the retinoic receptor alpha. And that fusion blocks myeloid differentiation. So you get accumulated pro-myelinocytes, which release granular contents, and that activates the coagulation cascade, and that's why you get DIC. And so the treatment is all trans-retinoic acid, which is going to bind the abnormal receptors and force maturation of blasts in remission. And by the way, indolent is going to be kind of like a lazy, not wanting to exert yourself, is what that means. All right, so APL is characterized by myeloblasts with needle-like inclusions presenting with bleeding and leukocytosis. APL is characterized by myeloblasts with needle-like inclusions presenting with bleeding and leukocytosis. So indolent's like slow growing and mild. All right, so just making sure we get all these really, really down pat. CML is the 922. You went to C, Philadelphia, 922. It's the BCR-ABL fusion. Acute lymphocytic, this is all in children. So 4 to 10, you have the TDT positivity. CD10 positivity as well. It's seen also in Down syndrome associated. This person's too old for that. Hairy cell is B cell cancer with hair-like projections. And so that's not the case because that would show pancytopenia, not high blast stuff. APL, that's correct here. Because our rods, DIC, all that stuff. So APL is caused by that translocation where you get the PML fused with the RAR alpha, and it freezes the myeloid cells at the pro-myelocyte stage, and so they can't mature. So promyelocytes, they're loaded with a bunch of toxic granules, the eosinophilic granules, and when they die or break apart, they dump their procoagulant substances into the bloodstream that causes the DIC, the clotting, and all that stuff. And the clotting factors of platelets then get used up, and so you get severe bleeding. So you clot too much at first, and that leads to the bleeding. So you see elevated PT and PTT because they're consumed factors, and decreased fibrinogen, increased D-dimer, that's from the fibrin degradation, and decreased platelets, and you get bleeding gums and all that stuff. All right, so there's the bottom line. And now here's our patient. Let's check out our patient and see what he has to say. Got to use those $10 credits. 5, 4, 3, 2, 1.
You've had nosebleeds and bruising for about a week, right?
Yeah. I feel worn out all the time.
Your labs show high white counts with a lot of immature cells, and your platelets are low. On the bone marrow slide, we see these needle-like inclusions, our rods in the blasts.
What does that mean?
What does that mean indeed? Well, the promyelinocytes are secreting their stuff, and it causes a lot of the overclotting. And so that's why our white blood cell count is going way up. Basically, the bone marrow is overproducing these immature myeloid precursors that can't mature, and so these blasts flood the blood, and it increases the total white blood cell count. So you get leukocytosis, and the cells are they're functionally useless, right? They can't fight the infection. All right, go ahead and try it, BB. Let's see if a chat works. Didn't work. Soon I'm gonna get this to work, guys. Don't worry. We'll get this grinding on. Whoa. Okay. So on to our next question, shall we? Soon this will be just a polished machine. Hey, BB, welcome back. Okay, promyelitic leukemia versus ALL in children. Promyelitic leukemia has the promyelinocytes. Okay, I'm almost getting this to work. But we'll move on to our next question in the meantime. Question 92. So generate a patient. Diabetes. Good guess. Good guess. All right. So here we have a 70-year-old man presenting to the clinic with progressive fatigue, back pain, and frequent urination over the last 3 months. He has a history of hypertension treated with lisinopril. On physical examination, he appears pale, and there's tenderness over his lumbar spine. Lab studies are showing all this stuff here. We have low hemoglobin. Calcium is at 11, so that's high. There's high calcium. Total protein is at 9, so that's high. And we have trace proteinuria. Lumbar spine is showing some multiple lytic lesions as well. What's responsible? So we have back pain and lytic bone lesions, and so there's going to be some osteoclast activation there. And so this is the crab mnemonic: elevated calcium, anemia, renal dysfunction. So crab is calcium, renal dysfunction, and also anemia. And we also have that high protein as well. So all that stuff is making us think of multiple myeloma. Plasma cell proliferation, monoclonal Ig, M in the serum, cytokine-mediated bone reabsorption, punched out lytic lesions. So there's multiple myeloma. Malignant cells are overproducing the monoclonal immunoglobulin and activating osteoclasts with IL-6 and rank L signaling. And so these excess immunoglobulin light chains, Bent's shown, proteins damage the renal tubules, causing mild proteinuria and renal insufficiency. So erythroid progenitor cells cause polycythemia, not anemia, no relation to bone lysis or hypercalcemia. Mast cells produce histamine, seen in allergic disorders and mastocytosis, not monoclonal gammopathies. T lymphocytes mediate cell-mediated immunity, not lytic. And osteoblasts build the bone. All right, let's look at the pathophysiology here. So we have these neoplastic plasma cells are overproducing IgG or IgA. And we have IL-6, acute phase reactant, and also rank L, stimulating osteoclast. You get bone reabsorption and hypercalcemia. And then you have bone marrow crowding, so you decrease red blood cell production, which causes the anemia. The bone crowding. So multiple myeloma is all about those malignant plasma cells, the monoclonal antibody overproduction, and the bone destruction and anemia and hypercalcemia and renal damage. That's what's going on. You also get the light chain deposition, proteinuria, and renal dysfunction. All right. So the crab findings are you have the M spike and you have hypercalcemia, renal, and anemia, and then bone lesions. Thanks, BB. Trying to get this to work. All right. Let's look at these other answers and discuss why it's not them. Erythrocyte progenitor causes polycythemia. Mast cells would do allergic reactions through histamine release. T cells are involved in cell-mediated immunity, and osteoblasts build the bone. Osteoblasts build that bone. All right, so here's the bottom line. Multiple myeloma is indicated by anemia, hypercalcemia, and renal dysfunction and lytic bone lesions. So the plasma cells are the culprit for that. Plasma cells are the culprit. All right, our AI patient has been loaded in. So let's ask him about his condition. Here we go. 3, 2, 1.
A 70-year-old man comes in with 3 months of progressive fatigue, back pain, and frequent urination. He has hypertension treated with lisinopril. On exam, he looks pale and has tenderness over his lumbar spine. Labs show hemoglobin 10, calcium 11.5, and total protein 9.5. Urinalysis has trace protein, and his lumbar x-ray reveals multiple lytic lesions.
Multiple lytic lesions. Okay, so look out for that crab criteria. Calcium elevation, renal dysfunction, anemia, and also bone lytic lesions. And the plasma cells are to blame. All right, so that is our patient. We'll watch it one more time.
A 70-year-old man comes in with 3 months of progressive fatigue, back pain, and frequent urination. He has hypertension treated with lisinopril. On exam, he looks pale and has tenderness over his lumbar spine. Labs show hemoglobin 10, calcium 11.5, and total protein 9.5. Urinalysis has trace protein, and his lumbar x-ray reveals multiple lytic lesions.
All right, so there's your AI patient. Imagine you're in the clinic with them. And what if they were to ask you, hey, could you tell me about the frequent urination? What is the reason behind that? Well, myeloma cells secrete cytokines like IL-6 that activate osteoclasts, which chew up the bone. And that releases large amounts of calcium into the bloodstream. So you get hypercalcemia because you're chewing up the bone. That high calcium interferes with the kidney's ability to concentrate the urine. And so it makes the kidneys less responsive to antidiuretic hormone. And that is called nephrogenic diabetes insipidus, or it's a nephrogenic diabetes insipidus-like effect in this case. And so the patient then loses more water in the urine. That's polyuria, frequent urination, and polydipsia and thirst, right? So bone breakdown, increased calcium, decreased ADH effect, and then you get the dilute frequent urination. Light chain protein damage as well. The cancerous plasma cells are going to release free light chains into the blood. These are filtered by the kidneys, and they're known as the Bence-Jones proteins in the urine. The light chains then damage the renal tubules, and it leads to a renal dysfunction, you get myeloma of the kidney. And that worsens the kidney's ability to reabsorb water and concentrate the urine and adds to the frequent urination. So if they were to ask you, hey, why is this guy having some frequent urination? That's your answer. So this is a good example of how you have to just know these mechanisms, and then you can answer these questions quite well. All right, on to our next question. So here we have a 10-year-old girl brought to the pediatric clinic by her father for evaluation of behavioral issues at school. She's been frequently interrupting the teacher, fidgeting in her seat, struggling to complete her assignments. She loses personal items, all this stuff. First line is going to be dopamine because this is clearly attention deficit disorder. She has a normal IQ. She's interrupting the teacher. ADHD, attention deficit hyperactivity disorder. Dopamine and norepinephrine signaling is dysregulated. She gives stimulants like methylphenidate to block the dopamine reuptake and increase dopamine release, improving executive function and attention. That's clearly the answer. Alzheimer's would be associated with acetylcholine. Glycine is inhibitory, not involved in attention regulation. Histamine is going to modulate arousal, but not first line for ADHD. And serotonin is involved in mood regulation, so depression and anxiety. All right, so ADHD is very common. Fidgety, loses items, all that stuff. Yeah, that was a quick one, huh? This one's pretty easy, not much to say. Methylphenidate, amphetamines is what you give them. And the symptom onset is typically before age 12. Still generating. There are over 6 million children in the US who have been diagnosed with ADHD. That's a lot of distracted brains. Does it work well? It depends. Yeah, but it does work well. And you ought to be, I think it's like the average life expectancy increases by 7 years for those who take the drug. Just because dysregulation in your life through other means just limits the amount of years that you'll live. And so it does work. Definitely works. Highly effective. Definitely like a game changer for these kids. Well, here's the bottom line. Yeah, I think it's interesting too, BB. First line pharmacotherapy for ADHD primarily targets dopamine neurotransmission. Dopamine neurotransmission.
Hey guys, it's Doug Gurney here. Today's
Okay, finally got this working. Not yet the chat stuff, but all right, BB, thanks for joining in. That was really fun. We'll see you on the flippity flip, and hopefully by the time you join, I'll have the chat all ready to go. Yeah, write down all the zingers. That'll be good. Thanks so much, BB. Thanks for stopping by. BB, you okay? All right, soon I'll have my AI patient generated and ready to go. It's just loading right now. But yeah, 6 million kids have ADHD. A lot of distracted brains out there. You got to boost the dopamine levels. That's the mechanism. Now let's check out our patient simulation. Oh, it already worked. It didn't notify me. Perfect. So let's listen to our AI patient and we'll see if we can diagnose this person with ADHD. 3, 2, 1.
Her behavior rating scales show significant problems with attention and hyperactivity. We're thinking about starting medication to help her focus.
What does the medicine work on?
First-line therapy for ADHD boosts dopamine and norepinephrine. Stimulant medications raise those brain chemicals so she can stay on task and control impulse.
All right, so let's do this one more time because the initial part was a little bit wonky. So 3, 2, 1.
Her behavior rating scales show significant problems with attention and hyperactivity. We're thinking about starting medication to help her focus.
What does the medicine work on?
First-line therapy for ADHD boosts dopamine and norepinephrine. Stimulant medications raise those brain chemicals so she can stay on task and control impulse.
There you go. So she can stay on task and control her impulses. Impulsivity, attention, and declining grades. All that is ADHD, so the go-to treatment is methylphenidate. All right, awesome. Moving on to our next question. Question 94. All right. So let's do this question now. A 9-year-old girl is evaluated by her pediatrician due to a 7-month history of difficulty concentrating in school and frequent classroom disruptions. She often leaves her seat without permission and talks excessively, much to the frustration of her teachers. Her academic performance is beginning to decline. We've already done this one. This is another, difficulty concentrating, leaves her seat without permission. This is another dopamine, is what she would benefit increasing the dopamine. Because she has ADHD. And what you have to know is this is going to be in more than 2 settings to diagnose ADHD. Dopamine deficiency in the prefrontal cortex is central to ADHD, and treatment involves increasing the attention with dopamine, methylphenidate. So here's the bottom line. ADHD management primarily involves medications that increase dopamine levels to improve attention and reduce hyperactivity. Waiting for the AI image to generate. Oh, it did work already. That's why I was waiting so long, because nothing was loading. Now we'll see how fast this goes. All right, I think we're ready to just try the next question here. I'm done coding a bit. On to 95. All right, a 45-year-old woman with a history of chronic back pain presents to the clinic with medication management. She has been taking high doses of oxycodone for several years and expresses a desire to reduce her dependency, but is concerned about withdrawal symptoms. They recommend buprenorphine. All right. So she's been taking high doses of oxycodone for several years. So she has some chronic opioid use and likely some dependence. And she wants to reduce her dependency, but she's concerned about withdrawal. So the answer is going to be D, D, which is the partial agonism with a ceiling effect to prevent the misuse because of buprenorphine. That's what the drug does. That's how it works. All right, so basically, a woman's been on oxycodone, and buprenorphine helps because it's a partial opioid agonist. It binds the same exact receptors, but it only partially activates them. Buprenorphine does. So think of it like opioid, but light. So it'll keep her from going into withdrawal, while its ceiling effects makes it really hard to misuse or overuse. So buprenorphine works as a partial mu agonist with a ceiling effect to prevent misuse. Even if they try, there's a limit to the euphoria that you feel. Great drug. Substitution with longer acting. Methadone is a full agonist. Buprenorphine is not. We're looking for the partial, not methadone. Substitution with a mixed agonist. Nalbuphine. These aren't tested, but buprenorphine is not a mixed agonist-antagonist. Rapid detox. Naltrexone. Buprenorphine is not used as rapid detox, but for maintenance. Symptomatic alleviation of withdrawal. Clonidine. They relieve the symptoms, but they do not treat the cravings that you have. Clonidine. No cravings for clonidine. So to treat them, you have to reduce the withdrawal and the cravings, partial with the ceiling. Naloxone would precipitate the withdrawal if you're injected, prevents IV abuse. It's a Schedule III substance, allowing office space, unlike methadone. Partial mu opioid receptor agonism. Buprenorphine helps to treat the opioid addiction without getting the patients high. All right, so the bottom line is buprenorphine acts as a partial agonist with a ceiling effect, reducing misuse potential in opioid dependence treatment. So this is the AI video from the attention deficit disorder patient.
Did you see the drawing I made? It's a dragon with like 20 wings. I bet I could.
Maya, in your seat, please.
Oh, right. Wait. Look at this one thing. It's cool.
Sit down, thank you.
Okay. But it's such a good idea, I can't just... never mind. Can I ask a question? Because if the answer is bigger than we think...
Yeah, she's got some ADHD. You got to give her methylphenidate. So that's, you need some dopamine there, right? Now let's wait for this next one, which is actually the question at hand. All right, so here is our patient. She's 45 years old, history of chronic back pain, and she needs some help with her medication management. She's got a desire to reduce her dependency, but she's concerned about the withdrawal symptoms. And so we're going to start on buprenorphine because it's a partial agonist with a ceiling effect to prevent misuse. So let's check this out. We'll ask our patient how she's doing today.
I've been on these pills for years, and I know I'm taking too much. I want to cut back, but honestly, I'm scared of what I'll feel like without them.
That's understandable. We can start you on buprenorphine. It's a medication that works on the same receptors as oxycodone, but only partially stimulates them. Because it has a ceiling effect.
There we go. So that's how we're going to help this patient. Whenever you guys are watching these, I'd really like for you to put yourself in the perspective of the physician. Treat these like they're actual patients. That's why I'm trying to reify this experience for you guys. But yeah, buprenorphine is the example. Hopefully that was helpful. Moving on to our next question. All right. A 45-year-old woman visits her primary care physician due to a 3-month history of numbness and tingling sensation of her right hand and forearm. She reports difficulty with fine motor tasks, such as buttoning her shirt. Physical examination reveals decreased sensation to light touch, vibration, and proprioception of the right upper extremity. Motor strength is normal and deep tendon reflexes are intact. There are no signs of atrophy or muscle fasciculations. Blood tests, including complete blood count and metabolic panel, are unremarkable. A cervical spine MRI is ordered, which the following is most likely the finding of the MRI. All right, so we have a 45-year-old. She's got some numbness and tingling in her arm, and she has no weaknesses. So her vibration and her position senses are totally gone, but her strength and her reflexes are normal. And so that means that her sensory tracts are what's hit, not the motor tracts. And so MRI has a cavity in the spinal cord, and it's pressing on the dorsal columns of the spinothalamic fibers, the dorsal columns.
Syrinx.
There it is. You have your syrinx pressing on the dorsal columns of the spinothalamic fibers. So it's a syrinx with the central canal at C7, springomylia. Stringomylia. The bottom line is cervical spondylotic myelopathy often presents with upper extremity sensory disorders and fine motor difficulties. MRI can show cervical stenosis. So you have to know that it's the dorsal and it's the funiculus of the spinal cord and it has the sensory fibers. That's important to know. All right, well, there we go. Here's our patient. So just as a reminder, she's a 45-year-old woman. She's got a history of some numbness and tingling sensation of her right hand and forearm. She's got some difficulty with fine motor tasks like buttoning her shirt. And a physical examination shows decreased sensation to light touch, vibration, proprioception on her right upper extremity. Motor strength is normal, and deep tendon reflexes are intact. And it's asking, hey, which of the following is most likely finding we're going to see on the MRI? So let's give her a chance to speak. Here we go. 3, 2, 1. All right, let's try that again. Let's give it another try here.
It's this hand again. It tingles all the time, and sometimes it just feels dull, like I can't really tell what I'm touching. Even something as simple as buttoning my shirt, I keep missing. It's been going on for a few months now, and it hasn't gotten any better. Strength feels normal, but the sensation is just off.
There you go.
Going on for a few months now, and it hasn't gotten any better. Strength feels normal, but the sensation is just off. It's this hand again. It tingles all the time, and sometimes it just feels dull, like I can't really tell what I'm touching. Even something as simple as buttoning my shirt, I keep missing. It's been going on for a few months now, and it hasn't gotten any better. Strength feels normal, but the sensation is just off. It's this hand again. It tingles all the time, and sometimes...
All right, there you have it. All right, 65-year-old man comes to the emergency department with difficulty breathing and dizziness. He has a history of hypertension and was recently started on some new antihypertensive medication. On examination, his blood pressure is 90/60, his pulse is 110, and his respiratory rate is 20. You can see that all that stuff there on the patient vitals. Which I've generated over here. They're accurate. So the lab tests show no evidence of myocardial infarction, and the patient is given a drug intravenously, which results in, let's pay attention, the increase of his blood pressure and a decrease in the heart rate, and the forced ventricular contraction is unchanged. What was given? Here's the bottom line. IV drug, likely an alpha adrenergic agonist, increasing blood pressure and decreasing heart rate without affecting the contractility. So the answer is alpha adrenergic agonist. So the blood pressure is at 90/60. As you can see, the pulse is at 110. So he's got hypotension and reflex tachycardia. And so he's started on new antihypertensive. So there's some sort of a hypotensive episode because he started on antihypertensive medication. And we give him the drug, and the blood pressure increases, and so the drug causes vasoconstriction. We know that. Heart rate is decreasing, so there's reflex bradycardia and a baroreceptor activation. And there's contractility that stays the same, and so there's no beta 1 stimulation because beta 1 affects heart contractility. So pure alpha agonist tightens the vessels, and the blood pressure raises, and the baroreceptors fire, and the heart rate will drop. And the heart strength is staying the same there. So alpha 1 agonists like phenylephrine will cause peripheral vasoconstriction, which raises the systemic vascular resistance and the blood pressure, and it triggers baroreceptor reflex, leading to reflex bradycardia to compensate. So the drug does not act like a beta 1 receptor. Its contractility is going to be unchanged. What about beta adrenergic agonist? So that's increasing the heart rate and contractility. That's not seen here. Alpha adrenergic antagonist. So that would cause vasodilation, so it decreased the blood pressure, and it would cause a reflex increased heart rate, tachycardia. Muscarinic agonist. So that stimulates the parasympathetic activity, so you get bradycardia and vasodilation, which worsens the hypotension. Muscarinic antagonist. So that blocks the parasympathetic tone, and so you'd have increased heart rate, tachycardia, which is the opposite effect here. So the answer is A. All right, there's our bottom line. All right. Okay, there we go. So here's our patient, our 65-year-old man. Let's listen to him. Here we go. 3, 2, 1.
Hard. Catch my breath.
I know. I'm giving you some medicine now. It should help.
Okay. Heart slowing down. Feels a bit better.
Your pressure's coming up nicely. Just keep breathing with me.
Thanks.
So what did we just give him? We just gave him an alpha adrenergic agonist because his blood pressure was at 90/60, or his blood pressure is at 90/60. His pulse is at 110. So it's hypotension with reflex tachycardia. So the drug increases systemic vascular resistance without directly affecting the heart. Vasoconstriction, reflex bradycardia. Let's watch that again.
Hard. Catch my breath.
I know. I'm giving you some medicine now. It should help.
Okay. Heart slowing down. Feels a bit better.
Your pressure's coming up nicely. Just keep breathing with me.
Thanks.
All right, so the pressure was coming up, and the pressure came up because of that vasoconstriction. But then you have reflex bradycardia, heart slowing down is what he said. That's the reflex bradycardia. So you're increasing the systemic vascular resistance without direct effects on the heart. All right, we'll do like 3 more questions. All right. So here we go. A 35-year-old man has a history of hypertension, is admitted to the hospital for management of complicated urinary tract infection. On physical exam, his blood pressure is 130/85, heart rate is a 72. He's placed in a infusion of vasopressor to maintain his blood pressure, and then after administration, it goes all the way up to 160. Then he's given a dose of alpha-1 adrenergic receptor blocker. 1 hour later, his blood pressure is now lower, and his heart rate is at 92, was at 72. So which of the following vasopressors was administered? This should be a little bit easier because we did a question similar to this previously. So the heart rate is controlled by the autonomic nervous system. We should know of our alphas and our betas. And some medications have more affinity on one versus the other. So we have to balance all this out and know all the differences. So we give a vasopressor, and that raises the blood pressure to 160 over 95. And then after we give a selective alpha-1 blocker, the blood pressure is going to fall, but the heart rate is going to increase to 92. And so that means the drug has both a vasoconstricting and also a heart stimulating effect. So when alpha is blocked, the beta-2 vasodilator and the beta-1 heart effects are going to start to dominate. And so they drop in the blood pressure and you have reflex tachycardia. So let's just talk about all these drugs here. So first of all, let's talk about epinephrine because that's very commonly tested. Epinephrine activates multiple receptors. Activates the alpha-1 that causes vasoconstriction, which is going to increase the blood pressure. Also beta-1, which is going to increase the heart rate and the contractility. And also beta-2. And that's going to cause vasodilation, which then decreases the blood pressure in the skeletal muscle. And so normally, in normal conditions, alpha-1 and beta-1 are going to dominate, and so the blood pressure is going to rise. These guys are going to dominate. And then after you have that alpha blockade, the beta-2 dilation dominates and the blood pressure starts to fall and you get reflexivity. So you have the increased blood pressure initially, and then afterwards you have decreased. You have reflex tachycardia after the alpha blocker. So epinephrine reversal phenomenon. So we got that selective blocker. They get epinephrine, which acts on alpha-1, beta-1, and beta-2. Then blocking alpha-1 leaves the beta-2 unopposed, dropping the blood pressure. Baroreceptor response increases heart rate due to reflex tachycardia and direct beta-1 effect. And epinephrine has that strong one at higher doses. It's not phenylephrine, pure alpha-1 that causes reflex bradycardia, not tachycardia. Anytime you have a biphasic response to the alpha blocker, you should think about epinephrine. Epinephrine is used in anaphylaxis with its beta 2 bronchodilation and alpha 1 vasoconstriction. So here's the bottom line. Norepinephrine is the most likely vasopressor due to its alpha 1 agonism and subsequent blood pressure increase. Yeah, this is confused. Basically, just remember everything we talked about before. All right, so let's take a look at this patient here. 3, 2, 1.